All right, so we're going to get started here. This is our third in a series of webinars addressing managing COVID-19 for the otolaryngologists, hosted by our Department of Otolaryngology here at Jefferson. So for those of you who would like to refer back to the first two parts, they're listed here. And they have YouTube links so that you can watch them on YouTube. The first one referenced telemedicine. The second one dealt with managing patients both in your office and in the hospital. Tonight, I'm very thrilled to be joined by Dr. Stephen Piper. He's a Peter Herbert Professor and Chair of our Department of Anatomy, Pathology, and Cell Biology here at Jefferson. I'm also joined by one of my partners, Dr. Adam Luginbuehl. And as we've done in the past, we'd like to dive a little deeper into a particular topic. So tonight's topic is going to be COVID testing. As we've done in the past, I'd like to remind you to please note the date. Today is April 9th. And as we've seen in our previous webinars, in a short time of a week, things are rapidly changing, both in terms of the extent of the pandemic as well as our practices. So if you reference back to this in the future, consider where we were at this time. I ask that you mute your phones and microphones. We do invite questions. Please do so through the chat box, and we will answer them as we get to the end. Again, a reminder, this is our department led by our chair, Dr. Keene. We have a large department across several offices. So as we are figuring this out as a department, this is our attempt to share it with you, as we know undoubtedly you're facing similar circumstances. Here's a word cloud that we've referenced in the past as we pick through different topics that might be on your mind. Tonight's emphasis will be on COVID testing. Before we get to that, we'd like to run through a little review. As we did last week, any slide that has been presented to you before will be outlined in blue. This was from the very first week on March 26th. And if you recall, I told you that the number of confirmed cases on this slide was outdated from that morning to when we presented. That was the day we crossed 85,000 and became the country with the most cases in the world. Last week is on the left of the slide when we hit 234,000 cases, and this week is on the right of the slide. We're nearly double that at 450,000 cases. You can see the deaths in the United States have tripled in the past week. If you look at global cases, this was last week. We talked that the number crossed 1 million on the evening we were giving this presentation. If you look at this week, globally, we are now over 1.5 million cases, with an increase of deaths up to over 90,000. Pennsylvania, these were the first 2 weeks on the left. We just had over 1,000 cases and just over 10 deaths. On the right was last week, 7,000 cases. And now this week, we have more than doubled that, up to 16,000 cases, and we've tripled the number of deaths in our state. That moves us up a notch on the listing of states on where we are compared to other states. Most states doubled, and probably most alarmingly is that New York today, this afternoon, it was announced, now leads every country in the world in terms of number of cases in New York alone. Now, there is some good news coming out this week. And if you look at this graph and you notice the heat map to the right, you can see things are cooling off. And I reference on the slide here that COVID hospitalizations in New York in the past 24 hours was only 200, which is down significantly from 1,400 a week ago. So although New York's total numbers are high, their growth rate is certainly coming down. They did not double from last week. This I showed you last week. This was the heat map of Pennsylvania. At the time, Philadelphia County had a doubling rate of every 3 days. And you could look at a lot of the counties in the middle portion of the eastern side of the state. And this is the heat map from today. We're cooling off. This is good news. The doubling now for Philadelphia County is estimated to be 4.5 days. I showed you this slide last week, which was part of the White House press briefing a week ago Tuesday, where they made the sobering announcement that even with our blunted curve, if you will, we can expect 100 to 240,000 deaths in the United States. That model was based off of the IHME, which I also showed you last week, was predicting bed needs and ventilator needs for the entire country. The good news is this model has been recalibrated. And if you look, these curves look about the same, but please pay attention that the y-axis on the new one to the right is half that of the y-axis on the old one from the left. So the top of the left is 500,000 versus 220,000 on the right. So this curve has significantly depressed. And these two are the Pennsylvania curves, and these y-axes are the same. So you can get a sense that the curve has indeed flattened. This is good for Pennsylvania because it means it puts our estimates for number of beds and number of ventilator needs and number of ICU needs well within our capacity. Of course, that might differ area to area. And of course, there is a lot of caution regarding getting too excited about these numbers because social distancing and other strategies remain important. And then finally, we like to update you on major things that happened in the week. We talked about crossing 1 million cases. You all saw the announcement that the CDC would support covering of your face in public. Midweek, Boris Johnson of the United Kingdom was admitted to the hospital with this, and we've all seen reports of numerous celebrities. Curiously enough, it seems like a lot of musicians who have passed because of coronavirus. Yesterday, Wuhan, China, made news for lifting their lockdown and travel restrictions. So if you calculate back, I believe it was something like 78 days that they were on lockdown. And so some people try to reference that to get a sense of how long we'll be living like this. I just throw caution in there that Wuhan is far from back to normal. In fact, the residents who want to move around have to have a government-issued app on their phone so that they can be followed. Governor Wolf announced today that Pennsylvania schools will be closed for the remainder of the academic year. So the update, the summary, is the curve may be flattening. That's good. In terms of all of you and your practices and what we're facing at Jefferson, we have not reached the peak yet. And by no means are we in a normal practice pattern with things halted and direct patient contact at a minimum. And the reason we're focusing on testing is we realize that as we get over this peak and want to try to return or get to a new normal, we've talked about new normal, not return to normal in the past, that testing will be a key part of that. This is a quote from Dr. Fauci today talking about just that, that when we start to attempt to go to normal, we'll absolutely need to have the ability to suppress this virus from returning by identification, aka testing, isolation, and contact tracing. So with that, I'd like to introduce Dr. Piper again, who's going to give us an update on COVID-19 testing here at Jefferson. You'll have to, let me, yeah, are you muted? Unmute yourself. Yeah.
Okay, thank you, David. I've prepared one slide that is even more straightforward than a summary, so the most pragmatic can see the bottom line here. And I apologize, my arrow was moved by formatting. So for specimens, we use nasal swab, oropharyngeal swab, lower respiratory tract, bronchoalveolar lavage, and we have looked at the literature and spoken with our infection control team, and it looks like actually rectal swab may be a very good source of virus as well. Clearly, it looks like lower respiratory tract is a better source of diagnostic material than the upper tract is. And the other major message is that pre-admission testing will be available for patients with head and neck surgery. And we're planning to do that in the high throughput testing and not really in the point of care mode. Oh. So, in order to prepare for this, I tried to learn lessons from the 2009 influenza H1N1 pandemic. And so there are really four major lessons. One is a prompt assessment of the threat and develop an effective laboratory strategy for development of appropriate technology. Second, the management of laboratory staffing is really critical, both in terms of expertise and to avoid burnout. Third is enhanced communication and reporting is critical. And fourth is we need enhanced client services. So I'm going to go through our approach and kind of tell the story of how we developed testing at Jefferson. So the day that the CDC announced guidelines and announced their tests, we began setting up that test at Jefferson. It was basically following the CDC guidelines and the CDC protocol. And we did develop that test, and it was a low throughput test, and we didn't have automation to do that. Shortly after that, Roche received EUA, emergency use authorization for their test. And so I called Roche and said, please send us kits. And Roche said that they were under a governmental mandate to supply kits to reference labs and to New York, and that we would not get any. And so after multiple calls, I finally persuaded Roche to allocate testing at the level of 200 tests per day to Jefferson Health. And as I looked at numbers and as I looked at the evolution in New York, I realized that 200 tests a day was not going to be sufficient capacity. And so I needed to develop a backup plan. So what I did was develop what I would call a ramifying strategy to ensure that we would have capacity that was sufficient in a spectrum of technologies so we could offer testing at Jefferson, both in a high throughput testing center and in geographically distributed testing sites to provide nimble responses. So for centralized testing, we had the molecular pathology lab that has expertise in using assays at the high end of the technology spectrum. We had the Roche assay for 200 tests per day. Now it's been increased to 400 tests per day. We validated a Luminex system, and based on the relaxed guidelines by the FDA, we were able to show them that we should get emergency use authorization, and that was achieved on the 27th. We're still anticipating a higher need for capacity, and so we will get a Hologic Panther instrument and increase our capacity by about 100 to 150 tests per day. So that's the centralized high throughput testing. Then we wanted geographically distributed low volume testing that would be placed in multiple divisions. And so although it hasn't got, I guess just recently got EUA, we're planning on implementing the Luminex assay. It's a fairly low complexity test that works on a cartridge. It can do a run of from 1 to 12 samples, and it has about a 2-hour run time. We received the Abbott point of care test late last week. It's low complexity, it's low throughput, it runs one sample at a time. It takes 3 minutes for a positive detection and 13 minutes for a negative detection. So just to give you a timeline, Jefferson developed 2 assays that we got EUA from the FDA permission. One was the CDC-based assay, and that was on the 22nd of March. And then we also did the Luminex MagFix assay that we got EUA on March the 30th. We had 2 assays that had already been granted EUA and only required a mini validation. For Roche, we received kits on the 24th. In less than 20 hours from the receipt of kits, we did the mini validation and went live on 3/25. Similarly with Abbott, it had gotten the EUA from the FDA, and we went live at TJUH on the 6th of April. On the 7th at Jefferson, New Jersey, all 3 sites. On the 8th at Methodist Hospital, and on the 9th at Abington. And we were the 2nd medical center on the East Coast to activate the Abbott assay. So what are the advantages of our approach? All of the vendors had limitations in their allocation, and so by doing this essentially ramifying approach, we weren't dependent on one vendor for kits or capacity. In addition, we weren't dependent on a single line of instruments or technology platform, since many of those were backordered as well. We enabled ourselves to provide centralized high throughput testing, local rapid turnaround time testing with an intermediate batch size, and local ultra rapid point of care testing. Okay, so that's technology. Staffing has been a major, I would say, tour de force. At TGUH in the clinical lab, I think the technologists in the molecular pathology lab are the technology vanguards. They do the most tests at the highest level of the technology spectrum. We had the Cobas 6800 instrument for Roche, and our technologists had significant experience with that, so that was a real plus. We also had expertise in laboratory-developed test validation, and that enabled us to very quickly get the EUA from the FDA for the tests that we developed that hadn't previously been certified. The workload has been intense, and I'll show you numbers in a minute. We've been very concerned about burnout and really work overload of technologists, and there are some instrument challenges, and I won't go into those. So how did we approach staff? Well, we developed multiple technology-focused teams and also cross-training so that if we had a single individual exposed, we wouldn't lose a whole line of testing through a quarantine. We distributed the workload to avoid burnout, and even the senior members of the lab were very engaged in the testing to kind of monitor technologists and when they needed a break. We decided that we needed to recruit motivated, capable technologists from other laboratories, and this was counterbalanced by the fact that there was a decrease in workload in the routine laboratories. Inpatient work was down by about 7%, and outpatient work was down by 20%, with inpatient being about 3 or 4 times higher than outpatient. So this allowed some technologists to avoid being required to use ETO, and initially it extended our testing time to 2 shifts. Now with the Abbott, we can offer 24/7 testing. So the second was I've combined enhanced communication and reporting and client services. So with this heavy workload on the molecular pathology technologists, we wanted them to focus and use their technical excellence. We don't have any administrative support in the laboratory. And as I said, it was a very heavy load and a lot of pressure. So we decided that phone calls and clerical work would be a distraction. So we established a COVID-19 testing mini call center. We were able to receive essentially the loan of some senior personnel to help with clerical activities. And another aspect that helped us was the ED declined receiving calls for positive results. This shows the different map of the tests. The Roche test targets two areas of the COVID-19 genome. One is specific for COVID-19, which is target number 1 in this region of the open reading frame 1A. And let's see, how can I, there we go. And the second is in the E envelope gene. MagPix has a target in the open reading frame 1A and 1B. It also targets the N gene, which is nucleic capsid, and the E gene. Abbott targets an RNA-dependent RNA polymerase here, and the CDC assay targets 3 areas in the N protein. So the only one that has a coronavirus general target as well as a COVID-19 specific target is the Roche assay. Okay, this summarizes our testing overview. Since the 22nd of March, we've performed 4,649 tests, which is a little less than 10% of the annual test volume for the lab. You can see the distribution for inpatient testing, ED, drive-up sites, Methodist, and so forth. And I'm not going to go through all of these, but the major volume has been Roche Cobas. We've used Luminex as a backup. Abbott, we just introduced at the beginning of this week, but we're already up to 160 tests that have been performed. And this CDC-based assay, the manual assay, was basically to buy us 2 days of time before we got the Roche kits. So here's our breakdown. Roche has been the vast majority of our tests. Luminex MagPick is especially useful for some of the more viscous samples. The Roche instrument was designed to do serum and plasma. So some of the viscous samples have been rejected by the Roche instrument, and that's inconvenient to do the MagPicks. Then here's Abbott, New Jersey, which has gone live and doing their testing. And here's the manual assay. The positivity has been creeping up as we go. And here you can see a bar graph with the percent positive in each run, which is trending up. And in some days, it's been as high as 38%. That's more recently. So the last area that I want to discuss is a paper in Nature from a German group that just gives you an example of, first of all, the difference between upper respiratory tract and lower respiratory tract and the onset of immunity. So this is hard to sort out in terms of what the different specimens are, but if you just consider this as throat swabs and look and see that the majority of cases on this log scale are about 10 to the fifth. These are sputum and stool, and you can see the majority of these cases are above 10 to the fifth log in copies per swab. So this seems to be a much higher viral load. And it's summarized here, viral burden was higher in sputum and stool than throat and nasopharyngeal swabs. And then this is a timeline of days after symptoms when you see the percent of seroconverted patients. IgG in another paper was shown to come up very shortly after IgM, a little surprising, but you can see after symptoms, 5 to 6 days, about half of the patients now have detectable immunoglobulin against coronavirus antigens. This shows individual patients, and again, sputum is, or lower tract is orange, stool is gray, and this is nasopharyngeal swabs or oropharyngeal swabs. And for every patient, you can see that the viral load in upper respiratory tract is significantly less than lower respiratory tract. Maybe in these two, it's not that much different. But I think we've been working both with infectious disease as well as Boyd Hayne in pulmonology to try to come up with a streamlined approach and guidelines for the best ways to obtain specimens. And that's my presentation. I hope it's been interesting. I have my email address, and the true hero who's been the boots on the ground champion is Dr. Zixuan Wang, who's the scientific director of the Molecular and Genomic Pathology Lab. So thank you very much.
Good deal. Dr. Piper, thank you very much. It's very informative and clearly a labor of a lot of hours and time. And I'd like to take some of what you talk about here and just frame it for all of us as otolaryngologists, as what does this mean for us in our practice? Because ultimately, at the end of the day, probably many of us on this call are doing a lot of our work from our homes and doing telemedicine. And, you know, we all can't wait to be back and seeing patients in the office and then ultimately operating. And I think at this point here, we need to start thinking as a group what it's going to look like for us and start to plan and think through some of these things. And central to this, as Dr. Piper has indicated, is going to be the testing aspect. As we reintegrate ourselves into our clinics and our patients start to come through, we're going to have workflows. We're going to have thoughts about this. That's why this is incredibly relevant to us as we start to think about this from a reintegration standpoint. So primary testing method, as he mentioned, nasopharyngeal swabs recommended. We know this, it's PCR, but the sensitivity and specificity ranges 70%. We're finding, and Dr. Piper, is that about what you'd say is accurate right now? We're having about a 30% false negative rate. Would you say that that's accurate? That's the number I heard.
Yeah, I think it's in that range. And you know, in some of the figures that I didn't show, there seems to be day-to-day variability, perhaps from sample and not from the technology.
Right.
And some of the assays are more sensitive than others.
Mm-hmm. David, can you advance one? There we go. So right along those things, this is somewhat of a humorous thing for all of us that are otolaryngologists to see this, but I went on YouTube just to see how people are being tested. And it's, I don't know if it's I don't think they're directly related here or can be brought up on the screen here, but if you just look at this, you can kind of capture it in the video. This first one, the second one, and many of these, all three of these at the top, which are the majority of them, are showing the practitioner just swabbing the front of the nose right there as the entrance. And it's like a very official, this is how you do it. You put your mask on, you put your gloves on, and you take it and you swirl right in the front, and they're calling that a nasopharyngeal swab. I was going to show the videos just because I thought it was, for us as ENTs, a somewhat surprising that these are out there. But Dr. Teixeira is the bottom one. He does present a very nice depiction of this, and these may be performed in our offices. Certainly our office staff are well aware of how to do it, but it does speak to the fact that those that are performing these tests may not be well trained, and therefore the positivity rate may still be in question for some. And with 30% false negatives, it's a reminder that even though we might have a negative COVID test in the operating room, if it's a high-risk procedure, which we should at this point here assume all are high risk, that we would take proper precautions. Now, last week, Dr. Goldman and Dr. Cognetti talked about precautions, but proper, N95s and so forth when we're dealing with mucosal breaches and aerosolizing with bovies and lasers. Next slide, please. This is the testing timeline. I'm not going to spend a lot on it, but you can see the evolution over since January all the way up to now April 1st, where tests have come through. And Dr. Piper really brought home the fact that this is each week is bringing new and different technology, and the hospitals are having, at least thankfully through our leadership here, have a wide range of testing so that if one test goes down, there's duplicate C, there's different systems that can be used. And I don't want to underestimate the connections that have been made to allow for Roche and Abbott to be here in one of the first areas of the Eastern Seaboard. I do want to highlight April 1st, you see this FDA authorizing IgM and IgG. That's a blood test, and that will hopefully obviate some of the issue with the testing sampling taken from the nose versus being taken from the nasopharynx. I want to highlight that at the end of Dr. Piper's talk, he mentioned that IgG and IgM only rise after 4 or 5 days. So it's not great at picking up some of the very, very early stuff, at least as far as we can tell. Now, a lot of that data isn't out yet. But as you reopen your practices, it's going to be important that you start to look at and understand what type of testing is going to be relevant for the procedures you're doing. If you're going to be doing back to your regular practice, are you going to want a serology test? Are you going to want a nasopharyngeal swab? Are you going to want a 1 hour swab? Are you going to want a 4-day swab? These are all variables you're going to have to factor into your workflow. Next slide, please. So right now, as it stands, this is updated on 4/2/2020, so it's a few days old here, but there's 2 ways for you to order testing right now. One is through the Department of Health, where if you go to the center there, you call them and they provide the testing to those they think are at risk. If you as a practitioner want to order it, you can write a script or write an order through Epic or through your EMR. And have them go to a testing center. If you go to the next slide, this is a very fine pointed slide. Sorry, the other way. One more slide. These are all the testing sites in the Philadelphia area. And there's the website for it. And you can send your patient to one of those sites to be tested. And this obviously will change and evolve as time goes forward, as you reopen your practices where these people are going to get their tests done. Next slide, please. The Academy doesn't have a lot on its website right now regarding testing, except for this following statement. And it says, unless emergent surgical procedures should only be undertaken after ascertaining the COVID-19 status, and then performed using either N95 respirator mask with either goggles or face shield or a PAPR. And this kind of goes back to our earlier point that because there's a 30% false negative rate, and some of the swabbing techniques can just miss the nasopharynx altogether and miss therefore the virus, that we recommend that you have a high level of suspicion, even if the test is negative, if it's a high-risk procedure, which is pretty much all of ENT. And we'll talk about what high risks and aerosolizing means for Jefferson in a minute. Next slide. So these are two slides, the following two slides. This is for inpatient. This is an algorithm. We encourage you to reference it as you create your office and your own personal protocols for reintegration of your office into practice again over the coming weeks, Lord willing. Who knows when it will be, but this is adapted, and we certainly want to recognize University of Washington's effort in this, and we adopted it for Jefferson. I'm not going to outline what's on the screen, but I'm going to point out there's two of them. The second one is for the asymptomatic patient. This is what we have used in our department. So right now we're currently operating pretty much only on tier 1 patients, which are cancer patients or those that have emerging pathology that is life-threatening or going to alter vision. So for our sinus and skull-based team, they're dealing with vision changes or abscesses that could ultimately affect patients in that way. And go back a slide, sorry, stay there for a second. And as you see here, through Dr. Piper's leadership, we've been able to work out an algorithm where the patients are brought in the day before for the Roche test, which is a 4-hour test. They get that test, we get results back by 4 p.m. or 8 p.m., and the patient can then go to surgery the next day. As mentioned in the timing of things, the Abbott test, although is 5 minutes, it can only be done at one test at a time. So it behooves all of you to understand what test is in your hospital. For example, if the gates open up and we're all back to surgery, but we all have to do this testing, a huge bottleneck could occur with the Abbott test machine because it's one test every 5 minutes. You have, right now, let's say you have all the services, everybody that wants to intubate a patient, and you have 200 cases for the day. That just doesn't add up mathematically to be feasible. So you need to use maybe a combination of previous day testing. You don't want to have a 4-day test where the patient could become infected in the 4 days. So we're using a 24-hour Roche test as our baseline for most patients so that the Abbott machine can be used for those that critically need it. And as you see here, they go through this algorithm, which you can go back and look at if you want to reference it for your practice and development. Next slide, please. So this is the final slide, really just to drive home the thought that as we look for encouragement to look for up-to-date testing recommendations at your facility and around you. Know it well because it will become part of your workflow as you reopen. The questions you're going to want to ask are, what type of test? Is it going to be serology? Is it going to nasopharyngeal swab, oropharyngeal swab? The timing of the results, you're going to want tests in your algorithm that allows for a 4-day turnaround or a 4-hour turnaround or a 4-minute turnaround. Watch out for the bottlenecks that can happen with a single test. Important that you have this dialogue with your administrative hospital staff so you're not colliding with all your colleagues from all the other specialties. I would, just for a minute, if you could go back 2 slides. I neglected to mention one thing, this slide right here. The fine print at the bottom, Dr. Cognetti wanted me to highlight. This is the aerosolizing generating procedures. What is that? We're certainly evolving with this definition. 2 weeks ago, we would have said only procedures that involve the cutting of mucosa and, like, say, a neck dissection, a thyroid, or parotid would not have been on this list. That is no longer the case. We're considering anything that involves instrumentation of the airway. So anything that involves intubation, extubation, labor and delivery. So you can see that the definition of what's an aerosolized generating procedure has gone up dramatically, thus meaning that the testing is also going to go up dramatically. And you're going to be in competition with your colleagues to get access to these testing as you develop your policies. The one thing that would be noted is office-based procedures that are soft tissue, Mohs, small little skin excisions, things like that, where you're doing it under either sedation or under local. It may behoove you to think about things you can do under those procedures to prevent it from being aerosolizing. Obviously, anything nasal, anything mastoid related, anything ear or throat related all fall into that category, regardless of the type of intubation. Next slide. So again, the final thing here is timing, understanding that, knowing how you're going to work that into your workflow, when you're going to order the test and so forth. And finally, who should be tested? Those that get scoped, or is it those that go to the OR? I don't have the answers right here, right now, and I think that these will be an evolution as we start to open things back up. But it's going to be important that as we kind of get at the starting gate to consider our practices, that we think through this and dialogue together and continue to make sure that we keep our patients and ourselves safe. Because that's where I think the rubber is going to meet the road. And so I think if this becomes a relevant question to come back and revisit, next slide. If this becomes a relevant question to revisit or help design protocols that can be used at different institutions across the region, we'd love to help with that and try to articulate some of these things with the help of folks like Dr. Piper, who has the inside understanding of these testing and their relevance and their turnaround and their challenges. But thank you for joining us tonight. We're certainly thankful for all of the efforts and hope each one of you are safe and your families and your patients are doing okay. Dr. Cognetti, I'll turn it back to you.
Thanks, Adam. Thank you. That great summary there of what we're doing currently. And thank you, Dr. Piper, for that fabulous review of testing. I think it was great to put that into perspective for us and our audience. I'd like to open up to questions. So please type into the chat room and we will answer them. So this is a question I'm going to ask for Dr. Piper's help with. It says, what is the role of convalescent titers? Oh, we might have lost Dr. Piper.
No.
There we go.
I just need to unmute.
Okay.
So for frontline diagnosis, I think there are recommendations against using immunology, that it's less reliable than nucleic acid. I think in terms of convalescent titers, there's a spectrum of interest right now. One is just documenting the development of immunity, and I think that will probably be used perhaps even for allowing re-entry to the workplace for members of the healthcare team. There's also a protocol that's been set up by the FDA to look at convalescent patients. So they have to have been symptom-free for 14 days, had a positive test at the beginning of the disease, a negative test at the end of the disease, and they are being plasma-free for the possibility of treating patients with plasma, immune plasma, essentially. So I think that's kind of a broad spectrum of the considerations for convalescent titers. I think one of the questions is there immunity after infection, or can a patient be infected again? It doesn't seem that there's genetic drift in this virus, so it's different from influenza and HIV that come up with different closely related strains. The availability of ABIT testing for few patients.
If you want me to answer that one, I can. Yeah. So, because I've heard you speak before, Dr. Piper, that your job is to get us the testing, the variety of testing, and make sure it's available to Jefferson, and then it's others people's jobs to figure out who gets the test and how to operationalize it. So we're tremendously grateful for the amount of testing and the variety of testing you've provided to us and our patients. So the question is, what's the availability of the ABIT testing? That's the quick testing with low throughput for our same-day procedure unit patients, and how do we order it? So it will be available. There's a team working on the workflow for each hospital in the enterprise actively as we speak. If we showed you the algorithm, this is figured into it. But I will emphasize a point that Adam referenced a little bit earlier, in that these tests, so I believe it's 5 minutes for a positive and 15 minutes for a negative, Dr. Piper. So
It's 3 and 13, but yes.
So you can't expect to run all of your same-day surgical patients on arrival to the hospital. You wouldn't have enough time to start your operating room day. So it is encouraged that all patients still have the outpatient batch test the day or two before surgery. And the Abbott test will only be for those who truly can't make it in for the batch test. But we're working on how to collect the swab, and it is available currently at Jefferson. The next question is, please comment on reliability of tracheal aspirate negative test obtained later on an intubated COVID positive patient. And this is an interesting question because as we hit our peak, our specialty is being asked to perform tracheostomy on these patients. And when they're positive, there's some question, is there any benefit in waiting? And is there any role for retesting, or is that unreliable or not actually indicative of the patient's viral load or status? So Dr. Piper, I'll refer that to you.
Okay, I get the hard one. So I think there's variability in specimens. We've had specimens from patients that have typical symptoms where it's been a plug of mucus, small plug of mucus, and it's been negative, and that was one of the reasons we decided to work with Boyd Hayne to try to come up with guidelines on what's the best specimen. We've had patients who were intubated who had negative nasopharyngeal swabs and positive tracheal aspirates or tracheal swabs. So I really think that there's a tremendous value in optimizing the specimen and making sure that we get specimens that can be informative.
Yeah. And I can add one thing. I had 3 or 4 slides on this that I hid and did not show just for sake of time. And they involve this whole concept that early in the disease process, the viral load is higher. And as the patient goes further into the symptomatology of ARDS as the end, let's say that's the farthest they're going to get, the viral load seems to decrease as the inflammatory process increases. And there's a crossing of those lines as the IgG and the serology then become more prominent in the testing, and the nasopharyngeal swabs or the aspirates become less. I think the take-home message is to you, Ken, and to everyone, and I appreciate Dr. Goldman's leadership on this with our group, is we just have to have a super high degree of suspicion. Testing shouldn't affect the way we use our masks, shouldn't affect the way we approach the patient at the bedside. If it's positive, if it's negative, if it's high yield, low yield, I think we just come all at this with a high degree of carefulness.
And I did show a slide that showed that the viral burden decreased with time.
Yes, yeah, that's right. That one of those last slides there. Agreed.
So Steve, Bill Keene here. I just want to say on behalf of the department and all of Jefferson how grateful we are to have you on our team, because truth be known, Jefferson really is probably the leading organization in the Delaware Valley in terms of testing. It's your leadership and connections with commercial pharmacy has allowed us to have these testing, especially for those connections. So thanks for all that you've done. It's been absolutely incredibly important for us to be able to have you leading this charge. Well done. And the other thing
Thank you, Bill.
Real simply, Steve, is as we go to reactivate our practices, and I can remember when Vice President Pence was asked how many tests we can do a week now. I think he said 500,000. So as you look for us coming out of this economic doldrum, how many tests do you think we need to be able to do a week? And when do you think we'll be able to operationalize that to reach, say, 1 million tests a week?
So everybody has had bottlenecks in production, and initially Roche could make, I think, 800,000 tests a week, and now they're increasing, and there are more and more vendors and more point of care tests as well as batch tests. I think this will be a commodity in 6 months, maybe less. And I would liken it to HIV testing or flu testing or respiratory pathogen testing. I mean, once you know the answer, then my guess is this will be put in respiratory panels that become routinely tested. That's my guess.
What about the immunoglobulin testing as a way of determining when people can return to work or beyond the plasma donation? So if we bring our workforce back, how fast can we ramp up that?
So the word on the street, and maybe I shouldn't say this because this is going to be on YouTube, but I think certainly we aren't at a perfect world for the immunology testing. And the availability of, we've called the vendors Cellex and Euroimmune, and it's very difficult to get materials and kits. We're trying to work with a couple other companies, some of which have products that are close, I would say very close to being distributed. I think what we've learned in, again, a lot of different tests is the first to market isn't the best to market. And I think it will take refining the technology to really understand what it means. And there's not an FDA approved test for this. EUA is emergency use authorization. And so I think we won't know the answer to this until the dust settles a little bit. And I think it'll be important to have some sort of biorepository or panel where we can look retrospectively and get the answer with better tools.
Thanks, Steve.
Great. Thank you again. Thank you, Dr. Piper. Thank you, Dr. Luginbuehl, for assisting with the presentation this evening. Thank you to the audience for joining us. Obviously, as we've said in previous presentations, we remain available to you and your patients. If there's anything we can do to help, please reach out at any time. In the meantime, stay safe.
Thanks, David. Thanks, Adam. Thanks, Steve.
Thank you.
Bye, everybody.
Bye-bye.
Night.